Thank you so much for making the trip down to London or up to London or from side to London. It's great to see everybody here. This is our fifth Network of Excellence Pharmacogenetics meeting. We've got a packed agenda today. I know that some people have had some travel issues, so we might just need to shift the agenda around a little. We've got great speakers, delighted to have such a great program for you. So the Network of Excellence was set up just over 2 years ago. There's a number of work packages which we will address a number of those today, give updates on them and what the next steps are. One of the centerpieces was the progress study of pharmacogenetics in primary care, which John and Vidar will give you an update for, and a number of you in the audience have contributed enormously to that. There were a number of funded work packages, so there were pieces of work that funding went in from the NHS England to support that work. But there were also a couple of work packages which weren't funded, but we supported, so one around community pharmacy, and I can give a little update on that later on, and a program of work around pharmacogenetics and mental health. And as you'll see this afternoon, actually that will be a large centerpiece moving forward into the Network of Excellence 2. So we've had a number of meetings. We were here for a meeting a number of months ago, but we've also tried to be around the country, being in Liverpool, Newcastle, and we've tried, apart from just that program of work, to support colleagues who were really active in pharmacogenetics, developing different programs, often around a specific disease area or a specific indication. So colleagues from Keele, from Brighton, who are doing some work on asthma, which was presented in Manchester, colleagues in Oxford and Norwich, and we're really keen for Network 2 very much to have that same feel, where if you've not been part of the network or not funded as part of the network, we very much want to connect with you, understand what you're doing, so we've got a broader overview of what's happening in pharmacogenetics. But if we can, we'd really love to support your program of work. There's been lots of further funding and initiatives that have been generated through this network. So Munir's led a program funded by Innovate UK called CERSI PGX, which you'll hear him talk a little bit more about later, and a number of you have contributed to that very successful program. And then in Manchester, John, Vidar, myself and colleagues have worked with a number of companies to develop their diagnostic tests, particularly around pharmacogenomics. And that link with industry and regulatory elements, both between CERSI and Devote, is a really important area that we should push through to. I just wanted to highlight a couple of dates for your diary. So the UK Pharmacogenetics and StratMed network meeting is in the middle of June. That's always got a great agenda, some fantastic speakers there. So get your phones up and the QR code, we can put these things up later as well. And then later in the year, rather than having another network meeting in the autumn, we're planning on having a network meeting in about 12 months' time, which will organise and give you updates. But this autumn in Manchester, there will be a training course in pharmacogenetics. It's a 3-day program, and it's funded, supported by the European Society of Human Genetics and the ESPT. So we've got a wonderful faculty with colleagues like Ron here from the Netherlands, Jesse Swen, Mika Niemi from Finland, and some other colleagues from around Europe. That's very much going to be focused on people who have had little pharmacogenetics exposure, so pharmacists, GPs, colleagues that are interested in pharmacogenetics, but not necessarily some of the people in this room, because you're all semi-experts or experts, or bigger than experts. So it's my absolute pleasure to introduce Professor Dame Sue Hill, who's going to open up the day. Sue's been an enormous supporter of our programme of work and has very much had her finger on the pulse of what has been happening at a national level. So it's great to have her here today to tell us about her perspective of where she sees the next steps for pharmacogenomics. Thank you, Sue.
Good morning, and thank you very much, Bill, for that introduction, and thank you to Bill and the team in the Northwest for the clinical leadership that they've shown in this area of genomics applications within healthcare. I just commented actually to your comms lead, Bill. This is one of the venues I haven't been in before in London. So I've spoke at many, but I've never been in here. And I'm sure it's a venue we'll be using for the future. I also wanted to thank our pharmacy leads that work in each of the 7 genomic medicine service areas, because they've really championed the use of genomics, and particularly in the applications of pharmacogenomics, and supported by Vicky Chaplin in our national team. So thank you to all of them. And of course, with more money, we could do more, but we are where we are. So I'm just going to set out where are we heading with pharmacogenomics. And the 10-year health plan, and many of you will have heard me talk about this before, really put genomics centre stage for the transformation of health care over the next 10 years, with this commitment there that by 2035, 50% of all healthcare interactions would be genomically informed. A large chunk of that will be through the application of pharmacogenomics in healthcare pathways. And genomics as part of the one of the 5 big bets also needs to be thought of in terms of the data it's generated, or the data in terms of where it's needed in the system, and how we can use AI better. But a key part of the 10-year plan is also this whole development around innovation and technologies, and some of that is, of course, in the point of care testing area where pharmacogenomics will apply. So what the 10-year plan set out was that we need to move from where we are in terms of our healthcare system, that's one that's much more about late-stage disease, where all the money sits in secondary care. Very little money, if you look at it, actually sits out in primary and community care. So it's all about that left shift towards health, but also, and I'm glad Bill put up his slide at the very beginning, it's about bringing health together with growth, because the 10-year health plan was published at the same time as the life sciences sector plan. And in terms of the economy in the UK, it's thought that the two can come together in a mutually beneficial way. But 3 strategic shifts. And of course, what this means for pharmacogenomics is we will need to move more pharmacogenomic, either testing or access to testing, into the community. We will need to make sure that all the digital connections are right and it fits with the broader data and digital developments in the NHS, and that includes the links to the NHS app, which is seen now as the front door to the NHS for patients. And then it also needs to take us into a much more preventative healthcare system for the future. And I do think that in terms of pharmacogenomics, we can think about them being preventative in terms of reducing adverse drug reactions, in terms of making sure that we've got preemptive information for healthcare interactions. So what the 10-year health plan meant for medicines optimization, informed by pharmacogenomics, said that it would be integrated into routine clinical practice. The use would be expanded to include population-level testing, linked to also the over 40s health check, And that move towards preemptive testing, as I've already said, but integration into the single patient record and into the unified genomic record that will help us reduce adverse drug reaction and optimise medicines effectiveness. Then the second is all the work that needs to happen around workforce development and raising an awareness. And you'll see from Bill's slide at the very beginning, this network of excellence also looks at education and training of requirements and resources. But this will include how we train the neighbourhood health teams, but I would say what's emerging is it isn't just neighbourhood health teams we're going to need to train and educate. It will be primary and community care teams, as well as these emerging neighbourhood teams that includes working with local government, for example. And currently there are 43 neighbourhood health centre teams that have been established. And what we will be doing over the next year is working with a subsection of those and also with some primary and community care practices to really look and work through what pharmacogenomics applications might look like for them. Then there's all the digital developments that it recognised. But if you can see, it says enabling genomically informed prescribing, dispensing and administration of medicines and ultimately feeding into the clinical decision support. And we need to both have the guidance that Munir and his team are doing via CERSI, but also a knowledge base that primary and community care can link to, or give them the decisions ahead of time so they know what they need to do. And then finally, the ongoing support for large-scale research studies, including Genomics England adult population study in particular, that is looking at pharmacogenomics as being one of their big areas that they will focus on. So this is where we are in the NHS already, and many of you will know this, and I'm not going to talk about this in any detail. Only 40,000 tests are delivered every year. A relatively small number, the bulk of those in looking for a potential toxicity to the use of the fluoropyrimidines in chemotherapy, but also for the use in cardiac myopathy, for example, but in a minor glycoside toxicity. What this slide also illustrates, though, when we think about a pharmacogenomic application in healthcare, we do have to do all these other things in terms of guidance, documentation, in terms of working with the BNF, to ensure that it's embedded in the health system in a systematic and equitable way. And we were really grateful for the group of pharmacists and chief pharmacists who helped work on many of these documents. And this is a slide I've used frequently, and it features Ron Van Schaik, who's here today at a talk he gave in Stockholm, and I was in the audience. But what it illustrates is we're really in England just looking at the tip of the iceberg in terms of the testing we're doing. There are many other applications. And we are talking with MHRA about what the most appropriate applications may be for us to start to expand the list in terms of either what they see through the yellow card system or in other intelligence that they have that means that in a post-market surveillance perspective they would want to gather more information, or they think it might make sense in terms of the intelligence that they have. But our introduction is really dependent on the volume and cost. This network of excellence has done work on the potential introduction of clopidogrel in stroke care. Clopidogrel is used by about 1.2 million people in the population in England, not just for stroke management, but also for cardiovascular disease management in general. when we think about testing, from an NHS England perspective, we have to think about all 1.2 million coming forward, even though only a proportion of those may. So in terms of our discussions in the stroke care area, it will be very much about could we identify the high-risk group and target the high-risk group, which is what the Network of Excellence has provided some evidence, including on the testing. So some of it will be dependent on national priorities. And I think apart from DPYD, we haven't really looked in detail across the cancer patient pathway in terms of other drug gene pairs we might want to look at or pharmacogenomic applications. We need to understand the health economics, and as I've said from an NHS England perspective, we have to consider all patients in the population coming forward, and can we afford that, and can we do that, and how are we going to deliver it? Is our testing network able to expand? Is it able to cope with the volumes? Can we look at a relatively low-cost, high-throughput solution to enable us to think about delivery at scale? So as we move into what was a commitment in the 10-year health plan to create a genomics population health service, which we will introduce from the beginning of April, so fairly soon now, the testing offer, so right down at the level of working with defined primary and community care teams to start with in more pilot studies, with neighbourhood teams, a selection of those 43 that have already been identified, but many more to come online, is what should we do in the area of pharmacogenomics? And what we know is, and what we were committed to in the 10-year health plan, was for doing more testing in mental health, and in particularly in severe mental illness where there's polypharmacy and evidence of adverse drug reactions. But also, what can we do building upon the success of the progress study? And I think John's going to give that information out later. What you'll see, though, is the number of prescriptions that could be changed. You can see the acceptability by the primary care team of wanting to get it right for their patients. And so I think we have to move forward in starting to roll this out into these teams and starting to get the evidence. We will also, just for completeness sake, be rolling out more predisposition and inherited disease testing, not limited to just BRCA1 and BRCA2 testing, but also to familial hypercholesterolemia and other inherited diseases, very much led from a population health basis. So we start to flesh that unmet need out in the population. And then we'll be introducing in a pilot and evaluative study way the use of polygenic risk scores. So this will start, and it will also start to look at how the digital infrastructure can support this. And so we are looking very carefully, as I've mentioned already, about new models of care. When we look at pharmacogenomics, it might be in our current model of more reactive approaches, and that might be through point-of-care testing, where we can assess the outcomes through more traditional measures. The second is, as we've talked already, and what the progress study's been doing, is moving us into the area of preemptive testing, where outcomes are challenging to assess. And also what we want to know is, does it change prescribing behaviours over time? Does it actually mean that you've got a historical knowledge base on which we can affect and introduce future pharmacogenomic applications? And then our final area, where we are going to start and do this first of all in a pilot study, is for more the whole exome sequencing and whole genome sequencing that we're doing in the NHS, let's start to generate pharmacogenomic profiles, not just for the index case, but for family members, because that will move us on in terms of our overall approach to population health as well. And we can look for other additional look-for findings that actually fit with a population and a based approach in healthcare. And then this feeds into this overall, so that brings a little bit more life to where we are doing whole genome sequencing, which is the commissioned offer on the first line. So we can add pharmacogenomic profiles into all of those applications. And we will be working with Bill and the team to know how we can start to do this, especially through the analytical tools that have been developed and the ways of holding the data and pushing the data at the moment into primary care systems. But in the two big studies here that are being conducted by Genomics England, the Generation study, there is a conversation happening about whether pharmacogenomics should be part of that and should be held on record for that baby. Especially as they grow, some of those will have rare diseases, they'll receive multiple drugs, and having some information about their pharmacogenomic profiles will be important, but particularly in the adult population study where they're aiming to recruit 150,000 participants starting next year. So then to finish, we are focused, and Bill and the team are focused on really understanding the clinically relevant drug gene pairs to look at and exploring the applications and where the greatest benefit is, how testing could be delivered, the type of data and standards that are required, and then understanding what the patients and public want. And I would add a further dimension as they take this into the new network of excellence, which is around, as Bill already indicated, working with industry and what does this landscape look like as we move into the future. But we build upon Network 1 and into Network 2, and then we look at expanding the type of applications and how we work, as I said, through those neighbourhood and primary and care teams. And that will be working right down on the ground rather than actually in other ways that we've had previously. And I want to just come back to the point of how important CERSI PGX is. As we move forward, having these evidence-based guidance to guide both regulatory pathways but also implementation is going to be important. And so we'll be looking at how we work together with MNIA to make sure that we have the right evidence to support introduction within the NHS. So we know that the NHS has a world-leading genomics infrastructure. We know that the 10-year plan sets out the key role that genomics and pharmacogenomics will require. But there's a lot more we can do, we should do, we need to do. And the question is, how are we going to do it without having a lot more money to do it? And what can we do to start us on a journey rather than to get to where we want to do? But we shouldn't underestimate the scale of the pathway change that's going to be required from a clinical perspective to introduce pharmacogenomics and all the data and digital and workforce development requirements. And we've got a real opportunity through building upon Network 1 in pharmacogenomics into Network 2, and I would hope into Network 3, actually, Bill, to get us to where we need to be for our patients and our population. Thank you.
So Sue's not going to take questions today because she's got to rush to the House of Lords, so hopefully getting more money for the work that we're doing here. That'll be absolutely great. Lovely. Thank you so much, Sue, for joining us this morning. Right, so we're going to now kick off with talking about the progress study, and John and Vidya have been leading members of the team driving this programme work forward, and so there's still work to be done here, but we thought it'd be very useful to give you an update on some of the different aspects of the programme. So, John, the floor is yours.
Thanks very much, Bill. So yeah, really pleased to be here today to give an update on the progress study. And this is, should be said, still an interim analysis. We've completed recruitment now. We'll talk a little bit about the data that we're still expecting to collect from participants. But this has been a major programme of work that we've undertaken as part of the Network of Excellence over the past few years. And it brings together a number of the different themes that Sue has already spoken about, the concept of data and digital, upskilling the workforce, and that question of how do you actually deliver pharmacogenomics in clinical practice? How do you go beyond just generating genomic data and then actually moving that so it can be used at the front line? And we all know there's a huge number of pharmacogenomic implementation pilots. You can see there's been an exponential growth over the past few years. My chart's gone particularly small, so hopefully that's not happened for the rest of the presentation, but we'll see. And a few years ago, the PREPARE study was published in The Lancet, looking at a 12-gene pharmacogenomic panel to prevent adverse drug reactions, and the headline outcome of that was it was able to reduce adverse reactions by up to 30%. So a significant result, and lots of these implementation pilots have been at single institutions globally, thinking about how they deliver for their institution. But actually, how you implement pharmacogenomics across a health system is a different and, for many reasons, more complex challenge. As Sue has already articulated, despite lots of that evidence and despite lots of those pilots and lots of guidelines being produced by CPIC and now the CERSI, there's been relatively limited implementation in the NHS, limited to those 4 or 5 gene drug pairs. And so as part of our programme of work generally, but specifically within the NOE, we really looked at why does that gap exist? How might we overcome that gap? And does the health economic evidence underpin the meaning that we should overcome that gap? And so the first question we need to address of how you potentially overcome a gap like that is defining what actually is a pharmacogenomic intervention. And many of you will have heard me speak before about the fact that there's often a misconception that just generating lots of genomic data, well, the data itself is the intervention. That's not really quite true, because actually you need to take that data and get it to the front line. And so what we've tried to articulate is to split the concept of a pharmacogenomic intervention into this concept of the testing approach and then the model of service delivery. And this was published in a paper a few years ago around pharmacogenomics in the NHS. And very broadly, your testing approach, ignoring the technology you're using, but you can look at single genes, or you can look at panels. So single gene testing is really what we do at the moment. So someone needs mavacamten, they get CYP2C19. Someone's having certain chemotherapy agents, they get DPYD testing. You could do panel testing, where you look at multiple genes at the same point of time. But irrespective of whether you're looking at just one gene or a number, you need to get that into practice. And so you can use a reactive testing approach, reactive with planned reuse, or preemptive. And in theory, you can combine those different testing approaches with those different models of service delivery in any way you want. Some make more sense than others, but really what we're doing in the NHS at the moment is a reactive testing approach, looking at single genes. Groups around the world are moving towards this concept of panel-based preemptive pharmacogenetic testing. And to kind of express that schematically, which again, many of you will see me speak about this a little bit, but the issue is one of time. So using a reactive approach at the moment, you see someone in clinic, you think they need a pharmacogenetic test, you have to wait for that result to come back. And with a fair wind, you might get that result back in a week or two, you then get the result and you can issue or amend the prescription. Reactive with planned reuse is relatively similar. So you see a patient, you do your test, but you store that data in such a way that you can then use it to inform their healthcare throughout their lifespan, as Sue again was talking about this morning. And there's digital and data connotations to that, meaning that you need to make a way to make that data available. And then preemptive pharmacogenetic testing kind of gets around that issue of time, in the sense you're sequencing someone or generating that data before they present to you, and then you can access that again in the future. Again, huge digital and data challenges to overcome, but to think about that from a kind of pathway point of view, these are the different models that you could use. And the kind of growing consensus is the real issue is one of time. And if you to try and express that mathematically, then the utility of a pharmacogenetic test can be defined to an extent by the amount of time that you're waiting for that result. And the utility of a test, the likelihood of that test being used, actioned to guide prescribing, is maximized when that time is less than 0. And the utility of the test drops exponentially the longer it takes to get that result. So if you see a patient in clinic and you can generate a result 20 minutes later, then the chance of that informing care is greater than if it takes 6 months or a year. It's relatively logical, but it's important to consider this when you're thinking about how you might design a clinical service. And so we've done an awful lot of this thinking in how we've gone about designing our program, and we've thought about it from a kind of mathematical health economic perspective, but we've, as importantly, if not more importantly, gone out and spoken to people. So around the Network of Excellence, there's been a lot of qualitative papers published, and one of them was an interview program with GPs and acute medics around the country, and the feedback was appropriately quite blunt. And so people said, if I'm going to use this, I need the results to come back really quickly. I can't tell my patients to come back in 4 months for their prescription. That's completely appropriate. And then my favorite quote was, I don't want to think about genetics, I don't understand it, and I don't have the time or inclination to learn. It needs to be simple. And I think the key message to get across to absolutely everybody, and I remind myself this on a daily basis, is that most people don't care about genetics, and that's absolutely fine. I don't care about the intricacies of how you undertake a complex vascular procedure. I know it's important, but that's not my job. And so what we need to do, if we want this to be used, as Sue was saying, and it is kind of splashed across the 10-year plan, is create a service that people don't really have to think about it a huge amount. The data is there and it can be used. And we go from treating genomic data like this really exceptional thing that everyone needs to learn about, and how maybe mainstreaming was traditionally approached, to it being just another variable that's used in clinical practice. And that's a complex challenge, and clearly will involve elements of education, but it needs to be properly thought about in how we deliver that across a workforce. And so all of those ideas, all of those concepts went into and were formed to an extent or iterated as part of the Progress study, which was a multi-center implementation trial of pharmacogenomic guided prescribing in primary care. And so there were lots of things that we had to develop as part of that: the recruitment, sampling, the lab pathway, and then the actual tools to make the data available. So to go back to my slide earlier, we thought a lot about the technology, but we also thought an awful lot about the model of service delivery itself. And just to emphasize here, the objective of the Progress study was really that how. It's how you get the data out there. It was not designed, it was not powered to demonstrate the value of pharmacogenomic in clinical practice. It was not powered to demonstrate that X number of patients had a superior outcome. It was designed to show, can we get those results out there? How do we best do that? And is the guidance that we're issuing actually followed? Can you design a model of service delivery that is fit for the NHS, and then how can it be taken forward from there? So you can see the objective as written. So how did the study work? And many of you will have seen this, but it's important to probably reiterate. A patient would attend their GP. They'd be being considered for one of these index medicines, so an SSRI, a tricyclic, an opioid, a PPI, or a statin. And there'd be a conversation between the GP and the patient saying, there's a study ongoing at the moment to see whether we can use your genomic data to choose the best medicine for you. If they were interested, they'd take a study pack home. They would then go online. They'd consent asynchronously. They'd watch a nice video. Some of these pictures are taken from stills of that video. And then they would then provide a saliva sample in the pack that we'd given them. They'd post that in any postbox around the country, and then that would come back to us. What's really important to emphasise, and you'll realise later why this is important, is that we had two options that GPs could follow. GPs were able to either prescribe before the results are available. So this was a pragmatic implementation trial. We were just pushing that data out there into clinical practice. And ultimately, if they felt that it was appropriate to prescribe and then adjust the prescription at a later date, they were able to do that. So that was prescription before results. Or they could wait for the results. If they said, well, actually, it's fine to wait a week or two for these results, and then we will issue the prescription rather than amending the prescription, they could choose that as well. So results before the prescription were available. The samples would hopefully hit our lab a few days later. The vast majority of samples were tested just using the Genomic Bioscience Veridose Core panel, supplemented with digital droplet PCR to improve our calling of the CYP2D6 gene. And we just had 4 study genes. So again, a very simple approach, looking at 2C19, 2D6, 2C9, and SLCO1B1. We were aiming for a median end-to-end turnaround of less than 10 days. And that wasn't kind of just plucked out of the air. We published a few discrete choice experiments a few years ago looking at how turnaround time impacts the acceptability of a service. And so that was deemed an appropriate cutoff based on that program of work. We had 2 ways that the results were returned and could be viewed, and it varied depending on site. And again, this speaks to some of the digital work that was undertaken and some of the challenges that were faced in actually building those. This is a screenshot from the Geno platform. So this is a platform that we have at Manchester that's used for pedigree drawing and MDT management. We developed a pharmacogenomic, very simple application within that, where patients' data were uploaded. This patient was recruited because they were being considered for citalopram. You can see that they're an ultra-rapid metabolizer, and there's a red flag recommendation saying that you should consider an alternative. And if you clicked on more detail, you'd get alternatives of what they might be. And then you can, if you want to, you can view the actual pharmacogenomic results further down. We've spoken an awful lot in the past before about the importance of making these data available within the prescribing workflow itself. And so the challenge with something like Geno, or if you were to issue them via a PDF report, is that's not how clinicians, healthcare professionals would normally go about prescribing. It breaks that workflow. And so what we wanted to do is try to create a system where people could go and the healthcare professional will be prescribing. If they're prescribing codeine, they're a poor metabolizer for CYP2D6, you get a pop-up saying, hey, this patient's not going to respond. And so we worked with colleagues from FDB, from clinical architecture, to develop Progress RX, which was a way to store the data outside of the electronic healthcare record itself. And so there was a knowledge base built within that, this content management environment. And at a number of practices, approximately half of the practices, we were able to implement that. This is a paper demonstrating the cluster archetype we developed to store your pharmacogenomic results. And that's really important if we're thinking about scaling something like this, because actually ensuring that our data, the data, is stored in a way that is interoperable is really important for the machine readability across different systems. But we were able to demonstrate this could be implemented across EMIS systems, System 1, and we implemented this at Epic, at our hospital in Manchester. And this is what the pop-up would look like. This is a bit of a mock-up, and it varied depending on the EHR. But you can see these patients, someone's tried to prescribe codeine, they've been enrolled to the study, data's available, they're a poor metabolizer, you should choose an alternative. So these are the 2 approaches that we used. And the guidance that was returned, they were binned into different classes. So a green recommendation was there was no impact on prescribing, and so prescribe as normal. A clinically relevant flag, an orange flag, was where there were recommendations to continue with the dose as prescribed and the medicine as prescribed, but potentially increased chance of an individual not responding, or increased recommendations about monitoring, or optional recommendations. And this is all as per CPIC, by the way. A red flag was where you should change the dose or you should change the prescription based on your initial index recommendation and the guidance. So this is how we measured the type of guidance that we were pushing out. Just to say kind of where we're up to. So prescribing behaviour was monitored as part of the study protocol. So Nicola and Eva did a huge amount of work as part of this. We're incredibly grateful, scraping that data from the EMIS systems and the different EHRs around the country. Follow-up data is being recorded for at least 6 months, and we've just finished recruitment, so that is ongoing at the moment. And the relevance of the data for previous prescribing. So we've captured all of the previous prescribing data from these patients, and again, that analysis is ongoing at the moment. The primary objective of the study, what it was powered to, was very simple, and we've used this for a number of studies in the past before. It's essentially to establish the proportion of patients who had a clinically relevant variant related to the medicine class which precipitated recruitment to the study. And we used a metric called the pharmacogenomic clinical utility metric, which we defined previously, which is just the individuals who carry a variant and are exposed to that medicine as a broad measure of potentially how this might impact on prescribing. The measures we felt were more interesting and more important were these secondary objectives, looking at how you actually implement this in practice. So the turnaround time from results to enrolment, the proportion of patients with clinically actionable or relevant guidance, and critically, what we're interested in is this guidance being followed? We were issuing these results either via ProgressRx or the Geno system, but we weren't calling up GPs to ensure that they had changed the prescription. This result was out there and they were able to use it as they deemed appropriate. And so to give you some data that's been pulled together over the last few weeks, so there were 1,350 participants recruited to the study in total, and there were 1,424 individuals who were initially identified as eligible. 58 of those failed to return a sample, so there was that conversation, and then they didn't get it back in touch, they didn't consent or return a sample. We had 1,366 who did do that, but then 16 individuals withdrew thereafter, and so that led to our study cohort that I'm going to present here today. It's important to say that recruitment across study sites was not equally distributed around the country, and sorry that appears slightly small, but essentially that's because we had different phases to the programme and we brought sites on at a different time point. So you can see here the recruitment across the time frame of the study. The vast majority of sites for that first year were all in the northwest of England, which is why the vast majority of recruitment is there. And then you can see the distribution between males and females, and you can hopefully appreciate the relatively bimodal distribution around age, which is probably influenced by the fact that if you were younger, you were more likely to be prescribed an antidepressant. If you're older, you were being prescribed a statin and a PPI, and we've got some data that shows that. And you can see the spread of ethnicities here, so skews extremely white, but if you look at the proportion of individuals in those populations at the sites we're recruiting at, it's relatively representative of the UK population. So to think about turnaround, so how is this actually working in practice? So you saw the map, there's sites around the country. All samples were coming back to our laboratory for this study. And so we had turnaround time from the GP appointment. So just to stress, this is that first interaction between the GP seeing the patient saying, hey, do you want to take part in this study, to getting the results back. Our median turnaround time was 10 days. Our turnaround time from consent was 7 days. So there was often a lag, as you can see on the right-hand side here, from review to consent. So the patients would often take a little bit of time to log on, to consent, to send their sample. Relatively kind of few days for sample transit, which fits with how the Postal Service works. And then we're able to maximize or optimize that laboratory pathway. So just over 3 days, we're able to go from the sample hitting our laboratory to getting the results available, and then actually reporting the results back was often a day or a couple of days. So we've massively maximized that pathway, and you can see the fact this is a research trial, this is a study, that review to consent process takes a relatively long time. So this is part of clinical service, and you're not having to do that. We estimate that we could get these results available within approximately a week. So we're very happy with that, given how long it can often take to get genetic results. So it's unsurprising, because we've seen this in lots of studies previously, that pharmacogenomic variation was incredibly common across the study cohort. You can see the split by different pharmacogenes here with the key of the different metabolizer states or functions here. And if you look at that non-wild type variation in the study genes, approximately 90% of people carried a variant in one of the four study genes that could impact prescribing. And pretty much all of the participants, 98.5%, if you looked at the entirety of the AGENA panel, carried a potential variant of interest. But that's fine, that's good to know. Biobank studies have demonstrated that over a long period of time. But the really more interesting thing is, sure, they carry a variant, but is it related to a medicine that they're exposed to? And so you can see here the breakdown of the different medicine classes, that the majority of patients recruited either receiving a statin or a statin or a SSRI. And it's important to say opioids were only brought on as a medicine class a bit later in the study. If we looked at the proportion of individuals who carried a variant and that was related to medicine they were exposed to, we saw that around 50% of people had either an orange or red flag recommendation, and around 1 in 10 participants had one of these red flag recommendations, suggesting that there should be a change in prescribing based on that index medicine that was chosen and normalized based on the class itself. You can see a breakdown here across the different medicines. So we are seeing actionable recommendations or relevant recommendations issued on an incredibly routine basis. Again, fine, that's great, but is that actually leading to a change in prescribing? So pharmacogenetic variation, very common. It's relevant based on the medicines that people are exposed to, but is it leading to a change in clinical practice on the shop floor? We're just putting this information out there. We're not sure what people are going to do with it. And so what you can see here is that based on the class of recommendation, the guidance flag significantly impacted clinical decision-making. You can see the likelihood of having a prescribing adjustment based on your recommendation class here, and that was significant depending on your particular class. Now, if you looked at individuals who had an orange or red flag recommendation, around a quarter of all participants had their prescriptions adjusted in line with those red or orange flag recommendations, but we can see that a proportion of guidance is not followed. And so we wanted to understand which variables predict the likelihood of having your medicine adjusted in line with the recommendations as issued. And so what you can see here is quite clearly, if you have an orange flag or a red flag, you're far more likely, looking at the odds ratios down here, to have a change in prescribing. The tricyclic antidepressants, again, very wide confidence intervals, but the guidance tend to be followed less, but there are a smaller number of those. If your prescribing was delayed, had a significant impact on the likelihood of this data actually being used. And this speaks to the importance of thinking about how we design this in clinical practice, how we design this going forward for future programs or for clinical implementation. And that difference between your reactive approach and your preemptive approach. And what you can see here is the likelihood of having a prescribing change based on your recommendation guidance, which is down here on the bottom, but also whether your prescribing was adjusted before your results were available or whether your healthcare professional waited until those results were available. And it made a huge difference. There's still a significant difference based on guidance colour within those different groups, but clearly, if your results were available at the point when you were receiving that initial index medicine, that guidance was far more likely to be followed as per CPIC recommendation. And that follows what we were saying earlier about the importance of time, importance of having the results available at that point of prescribing. And this will very much inform, or should inform, how we go about developing large programs, our service implementation in the future, because we know the likelihood of changing that guidance is clearly informed by how we design this. Regarding data for future prescribing, so again, we're still collecting this data at the moment, but some early signals that it is being used. Around 10% of all participants, the results were accessed again to guide further prescribing. 80% of those were within the same class, but we saw around 20% related to another class as well. And then around 90% of participants, when we consented them, said they want access to their own pharmacogenomic data, and Vidya is going to talk a little bit about that. We have past prescribing data available for all our participants, and there's ongoing analysis looking at the potential value of using that information, and there'll be an exploratory analysis of how this variation correlated with agent and class switching or discontinuation. So the study wasn't powered to that, but is an individual more likely to have a change in their class after 6 months if the guidance was or was not followed. So we've demonstrated as part of this interim analysis, and again, we'll produce more data as time goes on, but using this reactive with reuse strategy identifies a clinically relevant or clinically actionable variance in half of all participants. Pharmacogenomic guidance results in meaningful behavior change. So this is making a difference when put out there into clinical practice, leading to prescribing adjustments for around 1 in 4 participants where that guidance is followed. We've spoken an awful lot about the importance not just of generating lots of data, not just of generating these insights and putting them in a PDF report, but actually showing it changes behavior, because that's the only thing that's going to make a difference. It's not just about producing all this data. And to make that happen, we've demonstrated that models of service delivery and workflow really matter. When results are available at the point of prescribing, you maximize that utility and maximize the likelihood of the guidance being followed. And this speaks to the value of a preemptive approach to pharmacogenomic guided prescribing with regard to model of service delivery. There's clearly huge complexity in how you deliver that and the health economic implications. But when we're thinking about how we develop these models going forward, we really need to think about time. So we talked about variations common, related to medicines that are being prescribed, and its changing behavior. The next step is clearly to demonstrate that this is leading to meaningful outcomes on an individual and population level. It's not good enough to show it's just changing behavior. Is this making a difference for the health service? And so this is a program of work that we're particularly interested in, and there's opportunities to capture that data through patient-reported outcome measures and routinely collected healthcare data. There's been a huge team that has been part of this. I want to thank, in particular, Nicola and Eva, who have ran this admirably and collected huge amounts of data for the programme, and our steering group as well. So thank you very much. Yeah, so I think Vidya is going to talk about the work we've done returning results, and then we'll take questions together. Thanks.
Thank you so much, John. It's been really exciting to see some of this data emerge. You know, a lot of work has gone into this this program, so it's really exciting to see some of these insights come to life now. I'm going to very briefly talk about something that I'm very passionate about. As a surgeon, we're not always known for our communication skills, but I think it's extremely important how we communicate with patients, and returning results is something that, as John's already highlighted, was something that patients were particularly was felt to be particularly important for participants in progress. So that's something that we've thought a little bit about, and I look forward to sharing with you a little bit about how we've tried to approach that. So starting with why return results. So we've recently undertaken a large systematic review looking at public perspectives towards population-level genomics programs. And there's a few important perspectives that come out from that with regards to needs and expectations of the public. So firstly, there is a greater expectation for agency and people being able to take control of their healthcare decisions, and that's often driven by access to their healthcare results and healthcare data. There is a shift towards patients wanting to be seen as partners in their healthcare journey, not just as passengers that are being taken along, and that kind of maybe more traditional paternalistic approach to healthcare is certainly something that's changing. At the same time, being able to return results is a major motivator for people to want to participate in healthcare interventions, particularly around prevention. So it is a big driver for engagement. And actionability is absolutely key. So being able to return information to participants that they're able to do something with, or that has a meaning for their healthcare, is something that's extremely important. And pharmacogenomics falls squarely in that space, because the prescribing of medicines is the most common therapeutic intervention in healthcare. Many of us already take medicines or will take medicines as part of our lifetime. So being able to make a better informed decision about that through information is something that people are extremely passionate about. However, having said all of that, there's still a need for a healthcare system that helps participants navigate this information. So the expectation that there is a professional support around the return of information is still something that members of the public think is important. It's not something that's a wellness product or something that they expect to be able to manage completely independently, and therefore being able to have someone that helps them provide an explanation or guidance around some of the complexity and gives them confidence and understanding is something that's really, really important. This is also backed by some research that we've done ourselves, and one of the discrete choice experiments that John led over the last couple of years showed that patients being able to access their own results was a significant positive predictor of uptake. So if we designed a pharmacogenomic service where patients were able to receive their results themselves, that was something that people felt would make a significant difference to their likelihood of wanting to use that service. And in Progress specifically, as Rudy said, just under 90% of participants said that they wanted to have access to their own results. So that's great. So we've got a good, strong argument to do this, but this is not easy. How do we do this in a meaningful way that actually adds value to individuals as opposed to maybe creates more confusion or anxiety or additional burden on the healthcare system? And we don't do this very well at the moment. So this is a screenshot of the NHS app, and this is a result, a full blood count result, a very common piece of healthcare data that many of us will have had a full blood count in our lives. And this is something what a participant said related to this result. Say, I've had some blood tests the weekend, and on the NHS app, how do I interpret the data? So just being able to present data back is not enough. Clearly, there is a need for some interpretation, some explanation, some added context that allows people to actually derive meaning from that information. So raw data means very little. This is an example of a pharmacogenomic report that's commercially available that people can order, and they get a several page report that they can maybe look at or trying to understand. But really, this means relatively little to people. We've shown these kinds of reports to lots of public participants, and people say, sure, but what does this actually mean? And also the layout makes a really big difference, how the information is presented. The different medicines are at the top, but then the explanations or the clinical considerations are actually at the bottom. They're not written in lay language. They're written in a healthcare professional language. Even from a healthcare professional perspective, some of the language is not always very accessible, and there is no real action or instruction what to do with this information. I've got another couple of examples, if you'll indulge me, of again, these are just screenshots from commercially available products that are publicly available that you can order or get access to. So this is an example report from another provider where this is the information around amitriptyline. Apologies, it's quite small, but as you can see, the risk of ineffectiveness is increased and the risk of cardiotoxic side effects may be increased. The gene variation leads to increased conversion of amitriptyline to the active metabolite nortriptyline to less active and inactive metabolites. So is something increasing? Is it decreasing? Is it good? Is it bad? I've got absolutely no idea. This one is also quite funny, and again, so this is for codeine, genetic variation, etc. And then it goes on to say, this can result in an increased side effect. Death has occurred in children who received analgesic doses. One adult with reduced kidney function and co-medication with 2 CYP3A4 inhibitors became comatose after use of codeine for a cough. Thank you. That is really, really helpful. I'm really glad I paid, X amount of pounds or dollars for a report that's telling me this. So we do not do this extremely well at the moment. There was a nice piece of work that some colleagues in the States did where they qualitatively showed these types of reports to participants who'd had genetic testing to guide their care after primary coronary intervention. And most people said, I don't even know I had this test. And the people that did, I think 4 of them knew that they'd what the result meant that it was related to their medications, but nobody could really interpret it without healthcare professional support. So if we do want to return results, we need to be really conscious of how we do that in a way that's meaningful and adds value. So one of the things that we started off with, we worked hard with our patient participation group, as well as our GP colleagues and the study team, to first come up with a version of a letter that explains what some of this information is going to mean for them. And there is very clear instructions or explanations around the fact that differences in these genes are very common and are present in around 9 out of every 10 people. For this reason, there is no such thing as an abnormal pharmacogenomic result. So to illustrate the point that this is normal variation, it reflects how you as an individual respond to a medication. It doesn't mean that if you're a poor metabolizer that you're unwell and you have to go and admit yourself to the hospital, which is what someone could very easily interpret. Or if you're a rapid metabolizer, that you should be able to run really fast. That's not what that means. So being able to explain that there is no such thing as an abnormal result is something that was felt very important from participants as an example. And of course, extremely important that we highlight that people don't go and make unchecked healthcare decisions based on the information that they receive. Do not stop taking a medication that you're already taking. Do not alter your dose without speaking to a healthcare professional. So these kinds of things might seem very obvious, but this was felt to be extremely important. Having said all of that, it is still difficult to be able to present particularly gene drug guidance in a static format, in a PDF or a paper format, that doesn't end up being 25 pages long, that doesn't end up becoming confusing, maybe between red, amber, green, that doesn't end up being cumbersome to use when you're trying to find a particular medication that you're being prescribed in a quick and easy format. So being able to potentially do this in a digital format is something that kept coming up from the participants that we spoke to. And they said, well, I want to be able to search, or I want to be able to filter on types of medication. How can I do that in a paper letter? So we've just been exploring, working with a digital partner, of how we can support the return of results in an electronic format. And here it's really been really interesting to see the different perspectives on thinking about user experience. How do people click through digital tools? How we design the content in terms of hierarchy, colors, contrast in a way that's more meaningful and understandable? And how do people behave when they use tools like this? And how can we ensure that we want to drive positive behavior and not create undue anxiety? So we've been working with content designers, behavioral designers, people that we perhaps would normally work with to think about this in a little bit more detail. This has been reviewed by the Independent Steering Committee, and it's currently going through a revised ethics approval and information governance processes so that we can explore doing this in a more meaningful way. And I think this is really exciting because we want to learn how people engage with these types of services, both in a paper format and in a digital format. So what do we need to be able to return results responsibly and at scale? What is some of the IG and data infrastructure that's required? But probably what's most interesting is, do participants actually take this up? They've said, 90% of people have said they want to have access to data, but when it actually comes to it, do they actually do that? So what's the uptake? Do they actually understand it? Do we get a ton of emails to the study team that says, hey, wait a minute, you gave me this letter, or you gave me this app or whatever, but what does this even mean? I still don't get it. And do they maybe use it when they go and see the GP and say, hey, doc, or they go to the hospital and say, hey, I actually had, I was part of a research study where they tested how I respond to commonly prescribed medicines. Here is my letter. Can you please check that this is useful, or can you make sure that you prescribe medicines that are aligned with this? So what's the reuse for this? And also thinking about larger scale implementation. Progress is, I think, giving us huge amounts of learning around the how. So now the next step, undoubtedly, certainly with all the excitement that we've been hearing about this morning, is to start to think about how do we scale this up. So if returning to results is going to be a big part of future programs, what are the earlier opportunities to involve participants and think about this from the start of the study design? And how do we manage partnerships and relationships as we do that? Cool, so that was just very short and hopefully snappy. John, if I ask you to maybe come back up on stage and we can take questions jointly. Yes, thank you, very happy to take any questions, thank you.
Great, so I'm conscious that we're just a little bit out of time, but we're going to take questions because I think we'll have time through the course of the day to catch up and various things. So don't worry if the agenda doesn't look as if it's quite on track, and that's just me covering my back for my poor chairing. So any questions for John and Vidar? Ron, there's a microphone coming to you, so far away, please.
Yeah, thank you so much, great talk. I was trying to combine the two presentations. John, you talked about the progress study, and I was a little bit intrigued by the fact that you let the decision to the clinician whether to start directly before they had the result or to wait. And then when I go to the next talk, in which the patient is very important, I was wondering, did you consider, or perhaps you did, and I didn't recognize that, to have the patient decision in there? So does the patient want to wait? Give the patient a choice, like shared decision making, to start the medication before the result is there, or rather wait?
Yeah, so is this working? Yeah. So we left that decision to the healthcare professional and the patient. So we assume that decisions that are taken in that moment are made through shared decision making. We've done some qualitative work, which is yet to be published, looking at the interaction, how those conversations happened, what led to decisions within them, but we didn't pre-specify it within the protocol. It was about getting those results out there and seeing how people behaved with them. We expect that there must have been a shared decision-making process, and the reason I think that is because we've done analysis, which I didn't present here, which is because we were able to see the healthcare professionals and the site staff who were involved in having those discussions, and it's not like they do the same thing every time. There is variation depending on clearly who they're having a conversation with. So it was very pragmatic. It was up to the clinicians and not specified within the protocol.
It would also be very interesting to see that if the patient is involved in the decision making, how many patients would like to wait to have the right drug right away, and the patient that say like, okay, I want to have the medication right away. So it's very interesting, and I think you have the opportunity to investigate this as well.
Yeah, thank you.
Thank you. Great question. Yeah, Francis here at the front, and then we've got questions just behind there.
Thank you very much. Great talks. Thank you. My question is actually aligned to that, but I have a second question as well. So the first question was, I think you had amazing take-up, actually, that people actually returned their samples. But I wondered whether you've looked at the people that didn't return their samples, and were they people that had already got their prescriptions and then left and thought, I've got my prescription, I'm not going to bother return the sample? Yeah,
we don't have that data. We may be able to go back and look at that. That's a good idea. I think the reason we got such good take-up was actually the team, who many sat here, and there was a process for if an individual hadn't returned their sample, there would be a number of different contact points. And that's because we were very nervous that there was going to be this scenario where a healthcare professional was waiting for these results to come back, patient had just gone home, not returned the results, and then they were kind of forgotten about in a way. We didn't see that because obviously the healthcare professionals were very diligent, but we did put in these number of contact points. So that's why we saw such a high kind of return of samples. But yeah, we could definitely try and look if there's anything characteristic about those individuals who didn't get back to us.
Thank you. And then my second question, if I'm allowed, is, John, you referred to the consent for the study. Clearly it's a study, so you have to consent. But when we implement pharmacogenetic testing into the NHS, and maybe you won't be able to answer this, a bit philosophical, do you think we should be seeking consent as we do for genomic testing, and what might that look like?
No, I don't think we should take consent like we do for genomic testing. I think that consent should be proportionate to what it is we're doing. Just because it is genetic per se does not mean we have to have a 40-minute conversation and fill out a ream of paperwork. And that's been defined for over 2 decades. It's a great piece of work from Wellcome, I think in 2002, that defined that exact principle. Because it is genetic does not mean you have to do all these, take a specific process. So no, we have to think about what we're doing with that data. And I think it comes down to which technology we're using. If we're using whole genome sequencing and we're doing this preemptive model, then that does change the discussion. But no, just because it's genetic does not mean we have to do what we're doing at the moment.
Great. I think that's a consensus on the stage as well. I think Miles is just behind you, and then we'll take a final question at the back. So Miles.
Question for Vidar, actually.
Yeah,
thank you for walking through all of the enthusiasm there is out there in the patient community for being empowered for this. I completely buy into that. Sue told us about the ambition to embed pharmacogenetics in the NHS app. It does dodge a lot of the bullets around healthcare systems and difficulties of embedding in different EPRs and so on. Do you have that ambition? Can you tell us where you're up to with those conversations? Is it something that the NHS app developers are actively taking forward? Because it kind of feels like an obvious direction to go, doesn't it? And although you highlighted there are some rubbish private providers out there. There are also some really good ones, as I'm sure you've seen also.
Yeah, absolutely, and we very much buy into the idea as that for the NHS app to be the single front door for patient access to healthcare. I think in reality, the way that technology would work, and these are early conversations that we've been hearing from the NHS app team in terms of how they implement some of these. I suspect what will happen, and again, I don't know this is how I would strategically do this, is building everything physically into the NHS app will be hard. You need a large central team to do all the knowledge-based management, etc. What I see happening, particularly the way technology is emerging, is you'll have what's often described as an in-context launch or an in-frame, where you're in Google Maps and you click on a restaurant and you go to the restaurant's website, you maybe reserve a table at the restaurant, but you don't leave Google Maps. You're still using the Google Maps app, and similarly on LinkedIn or lots of things that we use, we stay within the same app, but we don't actually need to download anything separate or use anything separate or re-authenticate or re-log in. And I suspect that is the direction of travel, where the NHS app is the front door, but you have, as you're saying, good, high-quality, regulated providers that are providing data and digital services that are accessed through the NHS app, where the burden and the security and the compliance and regulation is not purely on the NHS team, but they are able to vet and work with people that are providing high-quality digital services through the NHS app as being the front door.
Thank you.
Fabulous, thank you. And there's a question at the back as well. Can't quite see. Is it Mark?
Great, yeah, it's me. How you doing? Very interesting to hear your thoughts on the genome sequencing needing a bit more robust consent, but in some ways we should be looking at it as a data query, so the proportionality of the consent should be on the data query that we're making of the data rather than the test itself, which kind of feeds in some of the points Vidya was saying as well around being able to push genome data or pharmacogenetic data into the National Genome Research Library so that we can use that across the country would be a major step forward for integration of private industry within the NHS. So that could be quite interesting to see how that will progress. I just had one question on thinking about the future. Moving forwards with being able to communicate to patients, and it was interesting yes, the text that you read out was quite confusing, but then it had a very strong recommendation of reducing the dose by 1.4 times below it, which seemed pretty concrete. And I think, thinking of this, it's around how we present the data to get the meaning that we need to the person at the right time to make the right decision. AI can be quite a powerful tool to be able to do that, to extract the right information. I hate it as AI when it's the hallucinating magical box that just throws out whatever we want. But more of the kind of big data where we've got very well structured information, guardrails in place that we get very well used information to the right person. How do you see that fitting into the kind of progress study and how we can implement that across different stakeholders within the journey?
So can I make one comment on the consent thing, and then you come in on the
Sure.
AI stuff? So on the consent thing, I completely agree. Again, just because it is WGS per se does not mean you have to use a specific consenting model. But I think if we're using models like we are at the moment, like if we're returning secondary findings, for example, then clearly people need to know about that. So I think it always has to be proportionate to not just the technology, but what we're doing with that information at the end. If you're just doing very straightforward queries of pharmacogenes that have no other relevance for health, there's a good argument to be made that you potentially could use a verbal consenting model. But again, all up for discussion, and yeah, really relevant point.
What I'd say about AI, and I've increasingly started to try to think like a designer, is it ultimately comes down to what's the job to be done, what's the problem that we're trying to solve, and really zeroing in on that. I think there are undoubtedly lots of high-value AI opportunities, either around perhaps some of the content generation for guidance, etc., or indeed for kind of big data analytics and extracting novel insights. But really, it ultimately comes down to what's the problem that we're trying to solve. I think the problem we're trying to solve with progress is not necessarily it's not really an interpretation or a data problem. It's not massively a laboratory science problem. It's really an implementation problem. How do you make this part of clinical workflows and clinical systems so we can drive better healthcare decision making and ultimately improve care and outcomes? So I think purely within that context, we haven't clearly identified an AI opportunity, but undoubtedly thinking about the future, thinking about scale, where we are doing this at a larger volume, are there AI opportunities? I'm sure there are.
Thank you very much, both. Vidya and John will be around all day, and so if you, at the breaks, want to catch some particular questions, we will be looking for other opportunities as the data analysis and things mature to present the data in updated formats, and there are a number of other work packages that are related to this. So Lee's, who's here in the audience, has done a lot of very nice work with Paul Wilson around implementation and getting opinions from health professionals. We've been doing health economic analysis. So there are quite a few other layers that we haven't quite surfaced here today that we'll be looking for an opportunity to share with you. So keep your eyes peeled. We'll update you when we've got more news. But John and Vidya, thanks so much for presenting. So we're going to now ask my colleague Emma McGavin from Queen Mary's, who's been working as part of our network team and has been leading some of the patient and public engagement work to give a little update on some of the work that was undertaken within Network 1. And Emma will be here again this afternoon because she's going to be doing some work in Network 2 as well with Ramona. So you come this way and then I'll go around.
Oh, thank you.
More dozy-do.
Thanks so much for inviting me to speak and for the introduction. Nice to see everyone here again. This builds on prior work that we presented at these network meetings where we had done some national survey work with the National Centre for Social Science around public perceptions of pharmacogenomics. So, as many of you know, I work closely with my local study, Genes in Health, which is run by David Van Heel out of Central and East London. And what he's done really nicely is create a longitudinal community genetic study with people who self-identify as being a Bangladeshi or Pakistani ancestry. And we had done some qualitative work with these participants some years ago, and some really interesting themes emerged. But the feedback we got also was that quantifying that would be quite useful to be able to make the most of the information from these participants to advocate within an implementation service. So this study that I want to tell you about now is sort of pending publication. So our latest update is looking at where we know there's low public awareness and potential disparities in pharmacogenomics uptakes across different populations that are likely to be relevant within a UK setting. So specifically, we wanted to look at the British South Asian community attitudes towards personalised prescribing using the window we have into that population with the Genes in Health study. So at the point of this study, David's group had recruited over 60,000 participants, and these are of British people of Bangladeshi or Pakistani ancestry. We think that's quite an important population to talk with in the UK because it's a rapidly growing demographic, and we know that it's dramatically underrepresented within both clinical trial and genetic study cohort data, and sadly that people are much more likely to suffer from cardiometabolic disease and also mental illness. And the relevance for high-yield pharmacogenes is that all of those intersecting factors mean this is an important population for us to talk to. So from qualitative studies, we understood from people that implementation of pharmacogenomics was thought to be beneficial. People loved the idea, as Vid so nicely highlighted, and that's an enthusiasm that we saw matched in the nationally representative survey that we did with NatSend. But they were concerned about potential risks of overburdening a resource-limited system. They thought generally pharmacogenomics was a great idea for the community, but there were concerns about data misuse and privacy at an individual level. And data sharing was thought to be a good idea, but people were really concerned about benefit sharing and that industry would sort of exploit information and gouge prices. So we went back to this study group of over 60,000 individuals and asked a small subsection to give us feedback on a recall survey. So we got 553 completed responses, which was an 11% participation rate, and we had a number of people that made it sort of halfway through or so. I think it was an additional 60 people or so. We weighted invitations to get representative responses from the cohort. So, for example, women responded at much higher rates than men. So in subsequent rounds of invites, we then waited to invite more men. And this study was entirely designed with the Genes and Health team, but also the Community Advisory Board, citizen scientists. And some of that was really nice because there were participant scientists who had done extensive focus group work with us years ago who then fed into this survey, so sort of continued longitudinal engagement. And the Community Advisory Board then felt more invested because they fed back into this, and then they'll help again the next time. So I think that mode of co-design is quite useful scientifically and also quite responsible, I feel, ethically. So this gave us the ability to give some quantitative feedback on what participants had highlighted from this study group around facilitators and barriers to pharmacogenomics. So the survey took about 15 minutes. We used a Qualtrics platform. I don't know how many of you are familiar with Qualtrics. Hands up, anyone ever used it, seen it? Yeah, it's quite a nice interface, I think. We gave people £10 vouchers for participating in the survey to thank them for their time, and we started sending invitations out in May 2024. So excuse the small font, but the overall format was first assessing basic knowledge, background knowledge in pharmacogenomics and why people think, or if they think there's variability in medication response, their experience with medication, self-reported adherence based on the Myers-5 scale, their use of traditional medicines, how they feel about pharmacogenomic testing, any concerns, where people would want results kept, data sharing of pharmacogenomics, and then potential for data misuse, feelings about education, community outreach, and any concerns specific to the British, Bangladeshi, Pakistani ancestry communities, and then awareness of the yellow card pharmacovigilance national reporting system and demographics. So this is what the survey interface looked like on, I think, a mobile, but it can be mobile or computer. And the point was to try to get the information we needed quantitatively to advocate for this population with national stakeholders. So our analysis of this survey first was descriptive, what did people say? And then we did some simple regression analyses looking at relationships between survey variables. As a secondary layer, we did some genome-wide association studies and pharmacogenomic candidate gene enrichment analyses around genetic architecture underlying herbal remedy use, and I'll come to that in a bit. But the use of traditional and herbal remedies alongside prescription medicines was something that the Community Advisory Board members and citizen scientists felt they really wanted it included in that work, and that was a complete change where an entirely new aspect of this came out just based on feedback from people. It wasn't investigator-driven. So most of these 550 respondents were between 25 and 50 years old, so it was quite a young skew to that compared to most pharmacogenomic data out there. 57% were female, and 2/3 had completed a university degree, and most of those people, that was in the UK. The reason there's this strong skew here is because we did do the survey only in English. And the most common primary spoken language was, in fact, English at 72%. And there were some interesting associations with language variables, which was that people who didn't speak English were more likely to have concerns around pharmacogenomic testing and more likely to want education. Most of these respondents were in paid employment. So what did they say? So it was quite nice that we had the nationally representative pharmacogenomics attitude survey that NatSend did such a beautiful job with before these results, because that allows us to stack up how a subpopulation that were concerned may have more concerns or engage less stacks up against nationally representative responses. And in fact, within this survey, more respondents felt they were taking a medicine which didn't work for them in the past, 72%, as compared with the national 45%, so quite a big gap. And more people had reported they experienced the side effect, and that was 54% compared with 46% nationally representative. So again, the numbers from NatSend were much bigger. This is 500-something people, but it sort of shows what we suspect, which is there may be an issue here. Respondent willingness to undertake clinical pharmacogenomic testing. So the questions were phrased differently from the national survey to this population, and that's because these question wordings were specifically designed for this population through these extensive stakeholder consultations. But essentially 58% of people agreed that they would do clinical PGX testing within this group. You might say 58%, that doesn't sound bad, that's more than half, but actually it's much lower than the nearly 90% we got nationally representative, and it's much lower than most of these studies that have predominantly upper-class European ancestry people suggest. So perception of impact on of pharmacogenomics on adherence. I think in this room we all have an interest in this, and we're all waiting some more definitive evidence base. But interestingly, people in this cohort felt just as strongly as the people in the national survey that about 70% of respondents thought that adherence would increase with pharmacogenomic testing. Now, with this survey, we asked people to score themselves on adherence, those who take medicines normally, and we associated the response on those MARS-5 outcomes with this. And actually, there wasn't a statistically significant relationship or even anything remotely suggestive between people's attitudes toward pharmacogenomics and adherence and their actual adherence to the medicines they take. So might think, okay, well, is it the people that don't normally take their meds that think they'd be more likely to take them if they had personalized prescribing? Based on this, not, but the numbers may just have been too small if there is something there. Concerns around pharmacogenomic testing and use of data. So 27% of these respondents had some concerns about pharmacogenomic testing, which isn't that high, but actually it's 30%, and that's just about the testing process. And 69% were concerned about potential misuse of pharmacogenomic information, which I feel is quite high. And it is higher than the nationally representative surveys as well, and that other sort of studies of more accessible individuals would imply. And the concerns were highest, as I think we all knew, around industry involvement with that data, and that's echoed through lots of different studies. But people were also quite concerned about academic researchers and even about healthcare practitioners misusing that data. And I think this next point is quite important. 87% of respondents would want stronger protections on pharmacogenomic information than non-genetic information. And I think we can all speak about this a lot. But the reason I think that's important is because as a group of sort of pharmacogenomics subspecialty experts, I think we skew really heavily towards PGX as a medicine optimization tool, and therefore actually genetic exceptionalism is not a helpful approach, and why should we have any more protections or special use around this data as compared to sort of a renal function or kidney function test. It's a really interesting discussion around consent, and I agree with John and the others that this doesn't mean we need to do genetic counseling for PGX results, but I think what it does mean is actually there needs to be a policy-level societal consent where there's some safeguardings in legislation and policy that don't currently exist. So I would think that actually this is a highlight that we should take quite seriously, in my opinion. And to underpin that point, 37% of respondents thought there were concerns unique to this specific ancestry population within the UK regarding pharmacogenomics. And there were free text answers, but it said sort of all the same things we've heard qualitatively, that people are concerned that groups can be marginalized, that ancestry structures can be identified, and that information can be used sort of against specific groups. Traditional or herbal remedy use, this was very interesting for me because the inclusion of this section of the research was, again, not investigator-driven. And actually, only 30% of respondents were not using any traditional or herbal remedies. And again, this is a mostly English-speaking, mostly UK-educated, university-educated population. So I think it's interesting how heavily used traditional remedies were. Now, most of these were black seed, turmeric, and ginger. From a PGX perspective, you know, these are all inhibitors of CYP2C9, which we know is a pretty important pharmacogene and also can interact with lots of meds we use commonly, like ibuprofen, phenytoin, warfarin. So there's an important clinical point there because 77% of these respondents were using these alongside prescribed medicine. And interestingly, those who reported not using any traditional medicine, that 1/3 of the group actually did have significantly higher MARS-5 adherence scores to the prescribed medication. So that's an interesting little tidbit, not something we were initially necessarily looking for, again, because this was not an investigator-led section, but it's something that needs further exploration. Now, because we had genetic data for this recall study, and because we noticed that all of this herbal supplement use was clustered around CYP2C9 inhibitors, and we know this is a population with quite high CYP2C9 loss of function variants, we sort of said, well, is there a genetic architecture underlying use of these medicines, either independently or in groups? And this man had, in case anyone's not used to looking at them, so this is a case control GWAS for turmeric use. We did them on sort of appropriate numbers where we had them. But it's an underpowered study. Nothing reaches genome-wide significance. But there's some peaks there that I think show that if we had higher numbers and clustered together, we may find something interesting here. And we're not aware of any study looking at this. So I think this is another way that maybe we can take forward some aspects of this that were really participant rather than investigator-led to understand more. So in terms of understandings of pharmacovigilance reporting systems nationally, a smaller percentage of this population was aware of the yellow card reporting system than within the national survey, only 4% less, but considering how educated this population is, that's still worth noting. And within the subset of people who did know about the pharmacovigilance reporting system, fewer of this cohort, as compared with the national cohort, knew that anyone could submit a report. So, what do I think we should take away from this? If we look at this subgroup as a, let's say, case example of an under-included sort of group within the UK that may be more reluctant to engage with pharmacogenomics, we can see that they were, in fact, more likely to report having experienced either a side effect or an ineffective medicine, less likely than national statistics suggest to engage in pharmacogenomic testing, quite likely to have concerns about the testing process itself, and very likely to have concerns about pharmacogenomic data misuse. So efforts to engage this group, but also many others, prospectively to integrate a successful clinical service are quite important. And again, I would draw a distinction between an individual level and a policy level discussion here. So I think we do need to consider that at a policy level preemptively, and of course culturally sensitive targeted efforts and addressing language barriers where they exist is quite important. Again, I think that we really need to take on board as a community that we hear from some of these potentially more vulnerable, sort of historically under-included research cohort communities, that they want stronger protections on this data than we might think this data warrants for medicine optimization. And I think we should also keep in mind that if we generate population-level pharmacogenomic data, it actually has lots of potentially inferable data that is not just medicines optimization in terms of population and family structure, et cetera. So again, draw that distinction between individual study level and subpopulation level testing and policy needed to have a safe and inclusive approach that will encourage trust if we do this on a national level within the NHS. CYP2C19 inhibiting traditional medicines. Within this group, clearly we all need to be asking people from this background a lot more frequently than we do in clinical practice if they're taking supplements. And people should be really aware of the common use of these supplements that impact on medications that are metabolized by CYP2C9. I do think that it's quite remarkable that it's a community where we know there's a real enrichment of loss of functional alleles, and then we see such high prevalence use of all of these CYP2C9 inhibiting enzymes. So perhaps there's something there, perhaps not, but warrants some further investigations. So I think that that's just a nice case illustration. Working with Genes in Health, we can work towards improving our risk-benefit ratio and facilitating trust. These are some very nice quotes from from participants within groups. That are representative of what many people said, which medicine suits me. I think that would be a good idea. So thanks to all involved, the Genes in Health participants and the Community Advisory Board, the Medicines Optimization Network for the kind funding, some of our other funders rather, and thanks to all the co-authors on this paper, which hopefully will very shortly be accepted for publication. And right, I'm not going to talk to that, so sorry. Yes, any questions, thoughts? I know we've run over, so I can also volunteer to talk to people at coffee if you want. Do you want me to defer questions to a later date?
Yes, unless there is one quick question. If there isn't, then we can move on. And Emma's going to be around all day and will be speaking this afternoon as well. Emma, that was great. Thank you. And I think it's really interesting the fact that actually your responses were from people who have taken part in the study, and so they're self-selected already. So there's a whole load of people that didn't want to take part who may have, more concerns that we aren't really drawing through. So that's really important. So thank you so much. Our colleague Catherine Payne's had quite a lot of challenges getting here because of Avanti. And so she's going to speak just after lunch. And so we're going to move straight to Munir is going to give an update on some of the work they've been doing around cancer pharmacogenetics in Network 1. So here we go. There's Munir. Thank you so much.
Thanks very much, Bill. So this is work that we've been doing as part of the Network of Excellence on cancer pharmacogenomics. It has several different elements. Why cancer pharmacogenomics? Why are we looking at cancer pharmacogenomics? So cancer is the poster child for precision medicine. However, if you look at the data, almost all the focus has been on efficacy, targeted drugs, etc., to be able to improve that benefit-risk ratio. And clearly, if you improve efficacy of a particular anti-cancer drug, then you are improving the benefit-risk ratio. Unfortunately, patients continue to suffer serious adverse effects associated with anti-cancer medicines, which can be fatal in some situations or associated with long-term disability. So survivor issues are becoming more and more important as patients are surviving longer because efficacy is getting better. So we really need to think about the safety aspects as well. And really, in terms of precision medicine and cancer, just the efficacy is just half the story. We really need to think about how we can improve the safety aspects as well. And that's what we've been trying to do in using pharmacogenomics, but obviously other people are looking at other ways of being able to improve safety using other technologies as well. So I'm going to give you 4 examples of the work we've been undertaking. Some of it has been funded from elsewhere as well. So DPYD, SG and UGT1A1, anthracyclines cardiotoxicity, and ICI-associated myocarditis. So let me start off with DPYD. All of you know this story, obviously based on data that came from the Netherlands, and Ron was involved in this and so on, from published in Lancet Oncology, highlighted the importance of these particular 4 variants, which was used by the regulators, the EMA and the MHRA, to change the drug label. And these 4 polymorphisms were introduced into the drug label and then implemented into healthcare practice in the middle of the pandemic, October 2020, I think. And in England, obviously, that went up to 38,000 tests per year, etc. But we know that these are all derived from European populations, and non-European ancestries inevitably are labeled as being wild type and therefore treated with the usual dose. 17% of the UK population is non-white, so it is important to start thinking about other populations as well in terms of how we use this. Otherwise, you start introducing inequalities into your healthcare system. So work we did as part of a systematic review, looking at many different papers which were published in non-white populations. We were able to identify many different variants, but we focused on this particular one, where there was much more evidence in terms of its utility, the 557A to G, which is found in African reference populations. It's shown to be functionally relevant, and we know that in the United States, it's already been incorporated in some DPYD testing panels, for example, in Chicago and in Mayo. They have been using that for a while. In terms of the UK, 2.4 million, that's 4.2% of the population, is identified in the Black, British, Caribbean, African ethnic groups. So we made a recommendation that it should be important to include this particular variant in DPYD testing. And we worked with Jess Keane to be able to send an application to the National Genomic Test Directory, and also worked with the Anti-Cancer Chemotherapy Board to be able to develop dosing recommendations in 2024. And good thing is that in terms of impact, last year, and I think it's just happened mostly this year, that the variant has now been included in the DPYD testing panel. So I think we've gone from 4 to 5, which is great, but I don't think this is the end of the journey. We should be doing much more. And as part of that, we've been working to recruit patients across the UK. These are patients who've had grade 3 or 4 toxicity and sometimes grade 5 toxicity, despite having been genotyped for the 4 variants, because this was mostly done when we had 4 variants. And you can see the unmet need here, that we've got 199 severe cases which have been recruited as part of this, highlighting the number of people who are still getting toxicity. And this is just part of the country. You can see there's lots of the part of the country which is not colored there. It has been a challenge to recruit patients into this study and so on, and to the adverse drug reaction studies. Most sites are saying they don't have the capacity to be able to recruit, even though it's very patients occur rarely, and it's only one-off sample and so on, which is a shame. Otherwise, we'd have many more. But nevertheless, it's still the biggest cohort in the world of that, of patients like that. In addition to that, we've identified patients via other sources, clinically recruited, for clinical advice, for example, from the Southeast GLH, etc. So we've got 238 cases and worked with Emma as well for East London Genes and Health and so on. And the 132 cases and the 106 clinical cases have been, we've got sequencing data on them, and we're identifying novel variants in those individuals. The manuscript's in preparation in terms of just sorting out some of the bioinformatics associated with it, but you can see there are intronic variants, there are exonic variants, etc., and many of them have pathogenic consequences in terms of predicted to have functional effects and so on. We're finding also compound heterozygotes. Some of those patients, for example, had one variant from the 4 variants we test for, and they then had 50% dose reduction, but they had such severe toxicity that some of them went on to die. Ideally, they shouldn't have had received this at all, or received 10% of dose, but probably should receive something different. Again, in order to be able to recruit patients from other ethnic groups and so on, we have been also undertaking international recruitment. We have got patients being recruited in this country who are not white. However, the numbers are small, and therefore we need to be able to expand that. So we have been undertaking work across these particular countries. You can see how many countries are on board, how many are coming on board, and how the others which are still thinking about this. Again, a huge challenge. Sometimes we're waiting for a year to get ethics approval for a quite simple study and so on. But nevertheless, we have managed to recruit about 100 patients, and more are coming through in terms of international recruitment. So I'll just move on to the next item. So we have just finished the guideline for the CERSI for irinotecan, led by Damisha. Thank you very much, Damisha, for this. And what we recommend for this, for irinotecan, is that anybody who's a poor metabolizer should have a 30% dose reduction cycle 1, with doses to be titrated based on tolerability and neutrophil counts thereafter. So as part, one of the other work packages we promised to do as part of the Network Excellence was to look at sacituzumab govitecan, SG, I'll keep calling it from now on, and Cinzia Del Russo particularly led this systematic review meta-analysis to look at UGT1A1 and took a very thorough assessment of literature, and I won't go through the whole flow diagram there, but literally basically was focused on randomized control trials where there was data published on UGT1A1 in those randomized control trials. And what we were able to identify were 5 trials at that time. Since then, there have been more published since we published this, but there's 5 trials at that time published. And what we were able to show from this was that with the SG, and sorry, I should have said what SG is for those of you who don't know. It's an antibody drug conjugate with HER2. It binds to the HER2 receptor, and you get then a payload from the SN38, which is the active metabolite of irinotecan, which is then released at cancer cells. The idea behind that is that you get the chemotherapy going to the cancer cell and hopefully less toxicity. But that, unfortunately, is probably less toxicity. However, there is still systemic toxicity going on. So many of the patients are still suffering with the same adverse effects as irinotecan, which is bone marrow suppression and diarrhea and so on. So you can see that when we do look at this, that patients with neutropenia, diarrhea, anemia of any grade, those who are homozygous for UGT 1A1 star 28 were much more likely to get this, which would be in keeping with irinotecan. And when you combine all the toxicities and look at particular severe end of toxicities greater than grade 3 toxicities, you get an odds ratio of 7, which is very similar to what you get with irinotecan given systemically and so on. So the idea here is that should UGT1A1 genotyping also be used with SG, as we are advocating for with irinotecan. And the suggestion would be that you could do a 25% dose reduction in UGT1A1 homozygous individuals, star 28 homozygous individuals. There was not much data on star 6, so we had to focus on star 28 here. The SPC, the product label for SG, highlights that if you do get a toxicity with SG, then the patient should have a 25% dose reduction. So you'll be in keeping with that. That's 25% preemptive dose reduction. However, we haven't taken that further forward yet, even though it's mentioned in the irinotecan guideline, which will hopefully be coming out soon, is that I think we need to take further work with breast cancer oncologists to get their views on this and so on, and take it further from that. And that's something that we're planning to do. The next is very much discovery-based studies that we wanted to undertake, really in the cardio-oncology area. And this has been led by Maria, and she's focused on 2 particular areas, anthracycline cardiotoxicity and immune checkpoint inhibitor myocarditis. As I said, it's very much discovery. If you look at the literature for anthracyclines, at least 40 candidate genes have been associated with this particular toxicity. Many have not been replicated, but 28 have been functionally validated using cardiomyocytes. And in Canada, particularly, Bruce Carlton and so on, in kids, 3 are used in clinical practice to guide monitoring. Now, people feel that these haven't been validated appropriately, so they shouldn't be used at this stage and so on. So there is much more work to be done in this area. And if you look at immune checkpoint inhibitor myocarditis, obviously, this is perhaps the most severe adverse event that can occur with immune checkpoints, and many patients with myocarditis end up in ICU or unfortunately go on to die. So literature suggests that 4 GWASs have been done. There have been reports of variants in interleukin-7, interleukin-33, receptor antagonist, etc. But there's also potential of somatic mutations which may influence whether you get myocarditis. But there's also probably underlying disease processes as well. For example, having ischemic heart disease or not having a very healthy heart probably increases your risk of getting this immune checkpoint inhibitor myocarditis as well. So you have to take that into account as well. So if you look at the anthracycline toxicity, and Maria has done fantastic work on this, and this has been extremely difficult to recruit to. You'll see that from numbers, but it was always supposed to be a pilot study. Anthracyclines obviously are mainly used to treat blood, breast, and soft tissue malignancies. And data which has been around since the last century, actually, is that there is an increased instance of heart failure over time when people have been exposed to this. And the cumulative dose people get is important as part of this. And obviously, heart failure is as a result of culminating cardiac damage. But if you look at the literature again, phenotype is different in different studies, which makes it difficult to actually think about replication. And so the phenotype issue is very, very important. And when we do studies in adverse drug reactions, we always start very, very strict phenotype. Because if you don't get the phenotype right, you can be very clever with your genetics, but you're not going to get anywhere with your genetics. So we have been trying to have a very strict phenotype, which restricts, again, recruitment, because many places don't have the kind of data to have this strict phenotype. So we've been using this kind of strict phenotype in terms of 10% changes, etc., or with or without symptoms of congestive cardiac failure within 12 months to be able to recruit. The other aspect is controls. Although we've got controls here who have been exposed, what we're finding is that the controls that we're recruiting are often younger than cases, and I'll come back to that in a minute. So how do we know who's going to develop heart failure in the future? So we have done some parallel work in UK Biobank to develop a polygenic risk score for heart failure, as well as do look at developing a GWAS. The idea here is that there have been studies on heart failure GWAS in UK Biobank. And what people do is they have an ICD code for heart failure, and then they look at the rest of the UK Biobank population as not having heart failure, and therefore use them as controls. However, there's a number of people in that control group who will go on to develop heart failure in the future, and these are the cryptic cases of heart failure. And Maria's developed a super control framework which allows you to be able to identify these cryptic heart failure cases and therefore exclude them from being controls. So what she did then was to exclude these cryptic heart failure cases and then looked at the actual heart failure cases versus the controls, super controls, as part of this. And what she was able to show was that she was able to replicate some of the meta-GWASs which have occurred with about 20 times higher population in terms of the GWAS which has been undertaken. So even with a smaller population, using the super control framework, you can identify the genetic loci which have already been identified in literature, but in addition, she was able to identify some new ones as well, which are shown in the red there, so new, which have got mechanistically important in terms of causing heart failure. So why is that important? Well, we need to be able to think about whether some of these heart failure loci are also important for anthracyclines as well. So we need to think about how we're going to sort of frame the control aspects and so on in terms of going forward. So if you look at, we've recruited, by the way, 35 cases so far. We've only got data from 29 in terms of the clinical data. We're waiting for CRFs to come back from those different sites. And we've got 35 controls as well, again, waiting for some of the CRFs. But if you look at the age is completely different between the controls and the cases. And we'll need to think about how we handle that in terms of looking at the genomics and doing the analysis associated with the age difference and so on. But nevertheless, the other aspects, as you'd expect, are pretty similar in terms of what they've been exposed to, in terms of duration of exposure, in terms of doses of exposure, and so on. You can look at a cumulative dose is actually similar. Well, slightly, sort of, there is a bit of a difference, but actually the variability is quite a lot. We have sent these off for genotyping, so we're waiting for the genotyping result to come back. So I can't tell you what the genotyping results are, but we're continuing to recruit and so on. As I said, challenge has been the ethics in terms of the recruitment. Ethics is fine, it's the recruitment that's been difficult. Oops, stuck. There you go, okay. And then the ICI myocarditis. Again, phenotype, starting with phenotype. The ideal thing would be to have cardiac MRI imaging done across all sites and when the patient presents and so on. But that has proved to be difficult. When we have looked at cardiac MRI, for example, Clatterbridge Hospital in Liverpool, cardiac MRI is standard in these patients, but actually when you look at the criteria, only 4 cases satisfied what we were using was called Lake Louise criteria in terms of making a diagnosis of myocarditis and so on. So we've had to change to a much more pragmatic approach, which is a more clinical phenotype, if you like, where you don't necessarily need a cardiac MRI and so on. And again, you can see that we have got 31 cases, which is quite a big cohort actually in this, together with 36 controls. However, I'm trying to identify others, so we've identified another 5 in Oxford, so we're just about to get those. And I'm just talking to Roche, who have got maybe 20 or 30 different cases of cardiomyocarditis related to ICI, so we're able to combine the data and so on, so to have a larger number to be able to undertake the work. So these have been sent for HLA sequencing as well as for GWAS, and we're waiting for the results to come back. So I'll finish here. Cancer safety pharmacogenomics is an important area for study. I think there's much more opportunities with the new drugs which are coming through. Challenge is recruitment. Cases are rare, and many trusts lack capacity, as I said, in terms of recruiting these cases. And I think the safety is probably not taken as serious as efficacy by the oncology community. I know there's lots of oncology specialists here. I apologize for that. You can shoot me at lunchtime, but it's probably not taken as seriously. When I've talked to oncologists, they say, actually, we can deal with that neutropenia. You don't have to worry about it. We're just more focusing on efficacy and so on. And as we know at the moment in the NHS, commercial studies are being prioritized, and we can't give them money to be able to recruit for every patient here. So that's been a part of the problem. So some of the drug gene pairs I've told you about are implementable, are already being implemented, but it may be in the future that others can also be implemented, but actually getting patient numbers and having mechanistic understanding as well as having good phenotype is going to be extremely important as we move forward. So I just want to thank all the people who worked with us for this, as well as funding from the NHS Network Excellence, as well as the NHS Race and Health Observatory. Thank you.
Thank you so much, Munir. Any questions from Munir at all? Yes, there's a question here. There we go.
Hi, thank you. I'm Anna Need from Genomics England. I was just wondering, when you recruited, or you found 199 patients that had severe reactions despite the genetic testing for the DPYD, were they predominantly non-white or more than you'd expect?
No, they were mostly white, but there were some people who sort of, of different ethnic groups as well. But most of the data we have is from white population, and again, highlighting some of those compound heterozygotes are so also white as well.
Thank you.
Thank you so much, Munir. I hope you get through lunch and we see you this afternoon. I'm going to invite Sian to join us. Sian Hilton is the Programme Manager on our Palo UK project that I'm co-leading with John. So we're just going to give you a little bit of an update about Palo. A lot of this hopefully will be familiar to you. We know that about 1 in 500 individuals carries a change in their mitochondrial genome. This 155A-G variant was described over 30 years ago, which predisposes individuals to profound irreversible hearing loss when they're exposed to aminoglycosides. And for the last number of years, testing has been available in the GLHs to test individuals where you know that they may be exposed to aminoglycosides at some point in their life. So these are often children with bronchiectasis or cystic fibrosis or bladder complaints, so you can order that testing. And now for the last year or so, rather than just the one variant, you can test for 3 variants. But the majority of aminoglycosides are prescribed in an acute setting. You can't plan that the person's going to have an infection that you want to treat, and particularly in the context of newborn babies, where if a baby's suspected of having sepsis, often very small newborn babies going to intensive care units are either susceptible to infection or have an infection. The standard treatment through NICE guidance is penicillin and gentamicin, which is given within this golden hour of their admission to the neonatal unit. And so you can't send a sample to the laboratory, wait 3-5 days for a result, and then that to come back. So there are different approaches that you could take, but we worked with a local company called Gene Drive in Manchester to develop a point-of-care assay, which we tested in the laboratory, showed that it was sensitive and specific and robust, but then wanted to test it in a real-life setting. We did that through the Palo study, which we undertook a few years ago. We showed that undertaking the testing didn't delay the time it took for those babies to be administered their antibiotics, so it still occurred within that golden hour, even though they were having this cheek swab genetic test undertaken. And we showed that we were able to identify 3 babies out of the 750 that were tested, that we were able to give an alternative antibiotic and so prevented their hearing loss. And so that was great. We got a nice paper, happy days, but that doesn't mean that that then leads to any change in practice. And so we worked to develop guidelines. The MHRA brought out guidance, and with GeneDrive submitted what's called an early value assessment to NICE. So this is, there's some evidence here, there's maybe only 1 or 2 studies that have been undertaken. What do we need to do to take this to a stage where it would be relevant for a full NICE proposal? And so what they did was they looked at the evidence that we had been able to generate to that point, and they said, well, what are the gaps? There were these evidence gaps that they identified. And so they were very positive about that initial data, but they said, essentially, you've undertaken that study in Manchester, which is a very big neonatal unit, very used to doing research studies. That is quite different to maybe a small neonatal unit. So neonatal units fall into 3 classes. So they're NICUs, a neonatal intensive care unit, there's a local neonatal unit, or a SCBU, a special care baby unit. And the levels of intensity of the interventions are different at each of those centres. So they're saying to us, does this test work? Does it cause the delay in time to antibiotic differently at different places? Is the accuracy of the test maintained? Will the test fail? There was a failure rate in the first study of around 15–16%, so you didn't always get a result, so that's quite frustrating. And they wanted to ensure that we could do this test in different geographical locations around the country, and also with ensuring that children of different ethnic groups were getting results that were just as robust across all groups. And so that led to the development funded by NIHR and the Office for Life Sciences for Palo UK, and Sian's going to tell you what we've done so far with that.
Hi everyone, thanks Bill for the invite and introduction. So yes, Palo UK, so it's a 2-year programme. It started November 2024, so ended October this year. So the design and to meet those evidence gaps that NICE identified. So there's 14 different neonatal sites chosen within the UK. 9 of those are classed as Group 1 sites, so those sites were already running the GeneDrive test already in their neonatal units, and then 5 sites were chosen that weren't running the test already, and then as part of the Palo UK programme, we would work with those sites and GeneDrive as the supplier to get them set up, installed, trained, and then running as part of the study. So there's a range of different units, as Bill mentioned, different size neonatal units, different levels of care. So we've got LNUs, SCBUs and NICUs in there. And as you can hopefully see from the map, the geographical spread, we've chosen sites to cover all of the 4 UK nations. So 9 of those are the Group 1, so 8 are within Greater Manchester, and the remaining sites are across the UK. So the sites and the period of recruitment at those sites were chosen to make sure we had enough data to look at that failure rate as well as the geographical spread in the evidence gaps. So the Palo UK study started, so it's a research study to collect the data in the same way as Palo. The primary objective is very much the same as the original Palo. So can we implement the point of care test without impacting neonatal care pathways, and to guide antibiotics without delaying any of that antibiotic and disrupting normal clinical practice. So in terms of progress and where we're at, we're all the way on the right in March, so we're nearly at the end of the research study, which is great. So recruitment started from March last year. We originally planned to do a minimum of 6 months, but we've extended that to make sure we get the sufficient recruitment numbers and data. So at the top we have the Group 1 sites, so those are the 9 sites already running the test, and then the Group 2 sites, you can see we've sort of taken a staggered approach. Those sites, we've got the staff trained up at the units, implemented the test, and then started the recruitment into the research study. So as part of the study, every baby admitted at these units during this time were tested under the Gene Drive point of care test as part of their admission pathway. So just some very sort of high-level preliminary results for Paleo UK. So this number is growing. The eventual target for recruitment is just over 5,500. So we're just shy of 4,000, but this is growing every day. So in terms of the test results received, we've received just shy of 4,000 results. Those are results from the Gene Drive test at the units. We've had just under 3,800 samples returned. So all of the cheek swab samples that are used for the point of care test are sent back to Manchester, and then we'll do a secondary test using Sanger sequencing on those. So far within the study, 22 positives, 20 of those have been confirmed as true positives, 2 false positives, and 0 false negatives. And failure rate, we're looking at this across sites, individually and as a whole. So it's currently a lot less than the original Paleo, between 7 to 8% for all data collected. And just in terms of some other analysis we've looked at, so we're just looking at from all of the babies admitted and tested, how many of those eventually received a valid point of care result during their admission. So after just a single test, which is 26 minutes, 92.55% of those returned a result within that time frame. Then after a single retest, that then jumped to 98.74% of babies had a valid result. And then we've looked at all of the babies and all tests, so sometimes babies were tested more than twice. That is 99.66% of all babies, which is a lot higher than the original study, so that's very promising results so far. And then in terms of Paleo UK, some of the outputs that are being gathered under the design will be sort of best practice principles and guidelines for other units to then implement the test. So in terms of training, we've worked with the units and Gene Drive, they've used different approaches. So in-person training for everyone to use a test. So we have advanced users and standard users. We've had online training, refresher training, and the train-the-trainer approach has been very useful just because of the percent of neonatal staff that need to know how to use the test is around 80% of all staff. So the train-the-trainer approach was key in some of those larger NICUs as well. Then in terms of the verification, so the genetic point of care test, the implementation of that, we wanted to make sure was standardised across all of those 5 new Group 2 units. So we've worked with a company, which I think was mentioned earlier today, EMQN, to come up with a standard protocol for all of the sites to use. So when they have the Gene Drive systems installed, they'll run a series of samples over a period of time, and then they can then be sure the systems are verified to use in their unit successfully and confidently. We've also used an external quality assurance scheme and enrolled some of the newer sites onto that. So that's been used. So every couple of months, samples will be sent from EMQN. The sites will test those and then feed the results back. So that's given quite a lot of confidence to the point of care teams at those newer sites as well. Then just in short, so next steps and impacts for the future. So the plan is to submit evidence for the evidence gaps to NICE summer, autumn this year. So as soon as recruitment ends, the data will be gathered, and then a formal report in terms of a manuscript will be submitted. And then we've had some recent conversations with NICE over the past couple of weeks, so that full assessment of the evidence gaps and publication of guidance is expected to take around 12 months. So currently expected summer 2027, subject to queries and how many committee meetings they might need. But that's the sort of date we're working to at the moment. And then just behalf of Bill, John and the Palo UK team, acknowledgements. It's quite a large team now and growing, so we can't fit everyone on, but the Palo UK sites are listed there and the investigators. So thank you. Probably hand back to Bill.
Thank you very much, Sian, and you've done an enormous amount of work to run this. I think there's a question right at the back, Chandra.
Hi there, Kate Downs.
Oh, hi, Kate.
The failure rate has definitely come down, which is great, but I mean, that's still quite a high failure rate for a genetic test where, you know, we'd expect a much lower failure rate within a laboratory. Is there room for manoeuvre to try and get that lower? Is this about sampling? Is this about the test itself?
So two things. One, actually, there's this sort of misconception that lab-based testing is pretty much perfect, and it's not. There is a failure rate in lab-based testing, and actually for some tests that's actually very high, and for some pharmacogenetic tests that's very high. So it's important to place that as the background. One of the real advantages of doing this type of implementation study is that we've been able at each stage to go back and try and understand the failure rate in more detail. So right at the beginning of the study, there was clearly some issue around the stability of the lyophilized reagents, and the company were able to add a protein stabilizer to that, so we saw an improvement there. The second area that we've spent quite a lot of time working at is, was there some nervousness on the operators, on the nurses, in taking the sample, the cheek swab, that they might disrupt or move the tracheal tube, or that they didn't want to cause any distress to, you know, often very small baby. And so we are able to look at the cellular content of the samples, and now in the failed samples, we're pretty much seeing that that there is DNA there. And that the sampling is getting better and better, and people are becoming more confident. So that has helped to see an improvement as well. So that's why we're seeing the drop. The remainder of the fail, we think, is predominantly due to the fact that the way that the sampling is set up with the cartridge is a little bit fiddly. We recognise that, and part of the problem is that if you overfill or underfill the cartridge, then you can get a fail. So the company are working on a way to, rather than using that cartridge in the way that it is, a more direct way of transferring the sample for assessment. So you're absolutely right. It's something that we're looking to improve and trying, you know, to get significantly down to less than 5% at the moment. We also see that there is some variability across the sites. And there's some variability that you can see with individual users. And so a person who has not used the machine for maybe 3 months, 4 months or whatever, they're much more likely to have a fail than someone that's using it on a regular basis. And so all of that's being fed into our training and our next steps. So thank you for your question. Ron, and then we'll move to, Ron and Emma, and then we'll move to lunch. Ron?
A little bit about on the same line there. I was triggered indeed with the false positives once. I was wondering, is the result directly transmitted electronically into the health record, or are the nurses have to put it in manually? Because a lot of mistakes are usually made by administrative errors, just like typing in the wrong result.
Yeah, so it's great that the number of false positives have come down. We have designed the assay with the company right from the beginning, such that if there were going to be false results, there were going to be false positives rather than false negatives, because clinically that's much more acceptable. And we haven't had false negative, so that's great. The number of false positives has reduced. we've thought a lot about how we move that information into electronic records. And of course, that's different at different sites, dependent on what systems they have, whether they use the BadgerNet system or whether that goes into an electronic record system. We have, within our own hospital, been able to have that information so it is then immediately available in the electronic record and appears as an alert if at a future point, 3 months, 6 months, a year later, that child comes in and the doctor wants to prescribe gentamicin or another aminoglycoside, an alert will pop up. So there are systems to ensure that that can be done, but it's really very variable at different sites depending on what their current architecture is.
My main worry is if a nurse has to put in the result manually.
Absolutely, absolutely. We're very conscious of, anywhere where you're transcribing or moving data in a manual way from one place to another, there are those issues.
And I'm a bit curious that you're only focusing on having the whole test being done at the neonatal care unit. We will be starting like in a couple of weeks, and we decided that we would have the samples going from the neonatal intensive care unit to the lab, and that we will process it at the lab. Of course, there's, like you say, handling the cartridge takes some skills there as well. But it will be very nice to compare results there.
Yeah, absolutely. And we know that there are different models of delivery, and around point of care testing, there will be certain scenarios, maybe with clopidogrel, and Vidya will talk about that a bit later, where actually maybe the time pressures aren't quite so acute, and so you've got a little bit more flexibility to have that testing done in a hot lab, on site where you get the results back much quicker. So it'll be really interesting to hear your data as that emerges. Emma, and then we'll scoot for lunch. Emma.
Thank you. So I was just wondering about the sort of envisioned scope going forward, because ideally we would have this as a medicine safety tool in NICU and it's routinely used. But in terms of ability to then look at sort of research potential for identifying novel variants within those genetic loci in harder to reach populations, are you envisioning a sort of scope for a registry or something like that? Because I would love to see a potential to go back to people who we didn't catch with this approach because perhaps we haven't represented their groups sufficiently in genetic studies, and then be able to use that as a discovery tool. Is that something that you think is possible?
It's not something we've spent a huge amount of time thinking about, in truth, but we do know that the 3 variants don't capture all of gentamicin-related ototoxicity, so that's absolutely true. How you capture that data further down the line and how you prove that the toxicity was truly due to the gentamicin rather than all the other things that have been happening to that often premature sick baby with multiple other medications is complex, and teasing that out. I know that the Elicard team at MHRA are putting quite a lot of emphasis on looking at new areas that they can interrogate in more detail, and using genomic data to explore that. So it's not something that we've done. We know there are a couple of initiatives around the world. There's a group in Oregon that have been doing some work in that space. But yeah, it'd be really nice if that was possible to make sure that once we've got this in place, we can make the testing more comprehensive and reduce these risks as much as possible. Brilliant, thank you very much. Right, we are going to now go for lunch. We're going to come back at 1 o'clock, so your lunch is a little bit curtailed, but hopefully you'll enjoy your food and drink and come for a break downstairs and have a chance to meet with people. We'll come back just before 1 o'clock because I want to start exactly at 1 o'clock if we can, and Catherine is going to share her health economics work. Thank you so much. Thank you, Sean. That was great. Excellent. Excellent. So now you're all set for the next one and the next one. Yeah, that was good. You were really good. Really good. That was nice.
No. Thanks for answering all the questions, though.
It's all right. I was at the lecture, so.